during this first two or 3 minutes of this webinar. So good morning, or good afternoon, actually, everybody. My name is Chara Rodriguez. I'm professor of family medicine at McGill and associate member at the Institute of Health Science Education and director of the Family Medicine Education Research Group. So I'm very happy to welcome all of you and to welcome to this FMER webinar with Professor Arch Mainous from the University of Florida as our guest speaker. As is customary in our webinars, our FMER graduate students facilitate the event. So today, Raymond Tolentino and Sima will fulfill this job. They are to the point to graduate this year, so we are very happy for them. So I will stop here, and Sima, Raymond, the Zoom floor is yours.
Hello, everyone. My name is Raymond. I will help moderate today's FMER Advanced Research webinar with Sima, who will also be managing the chat. We are both master's student in the Department of Family Medicine at McGill University under the Medical Education concentration. Before beginning, I would like to acknowledge the land that McGill is located on. McGill University is located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters on which we meet today. So for today's research webinar, I would like to introduce Dr. Arch Mainous, a professor and vice chair for research in the Department of Community Health and Family Medicine, as well as a professor in the Department of Health Services Research, Management, and Policy at the University of Florida. There, he was the chair of that department from 2013 to 2020. Dr. Mainous is an internationally recognized leader in primary care research with more than 450 peer-reviewed publications. His work has been cited more than 30,000 times with an H-index of 85. He has received the Distinguished Research Mentor Award and the Maurice Wood Award for lifetime contribution to primary care research from the North American Primary Care Research Group, as well as the Innovative Program Award from the Society of Teachers of Family Medicine. Dr. Mainous currently serves as a deputy editor of the journal Family Medicine, as well as a specialty chief editor of Frontiers in Medicine, Family Medicine, and Primary Care. Today, he will be discussing gaps in our knowledge that should be the focus for medical education research. Questions and comments from the audience are welcome and can be posted on the chat, or people can raise their hands after Dr. Mainous' presentation. The webinar will be recorded and will end at 1:30 p.m. For those who do not wish to be recorded, please turn off your video. And without further ado, Dr. Arch Mainous.
Yeah, thanks. I appreciate this. Appreciate the invitation. When Dr. Rodriguez reached out to me about 8 months ago, I was very excited. I thought I was going to get a trip to Montreal. Clearly, that's not the case. But I hope this is going to be fun anyway. So I get to sit in my office and talk, which I do all the time anyway. So there was a bit of a technical glitch on my part. And so if Dennis, can you pull up my slides, please? Let's go to the, yeah, so as Raymond pointed out, the title of this is Gaps in Our Knowledge for Medical Education Research. But what I want to also is the subtitle. We shouldn't only do the easy studies. I think it's very, I think it's what I want you to get out of today is that there are other ways we need to look at things. I think a lot of times people do medical education research by doing the most obvious ideas and with the easiest designs. I don't think that moves the field forward. I think that actually can be kind of distracting to building a knowledge base. So that's what I want you to do is I want you to be able to think a little bit differently at the end. There's going to be a lot of questions that I'm going to pose by the end for you to think about of potential things to look at, but I really want you to start from there. Next slide, please. So I have no conflicts of interest to declare for this particular talk. Next slide. So what I want you to do is, like I said, I want you to think and see the world a little bit differently. What I want you to do is rather than saying, well, here's the most obvious thing. Oh, well, we can look at this or this. I want you to come away with looking a little differently, looking at it from as looking sort of behind the scenes. Next slide. So what I do when I teach a class on health policy, one of the things I hit the students with, quite heavily is to think of unintended consequences. We typically don't think of that. We typically say, well, we want to just evaluate this program. We want to look at this. But a lot of times, there are unintended consequences. And it happens in policy all the time, and it happens with new technology. So I'll tell you an example of one that people talk about is you'll see that I'm sure this is on the tip of your tongue when people talked about in 1894 in the Times of London when they talked about with current population growth that with all of the horses and buggies that there would be 9 feet of manure for all the streets in London. Okay. It didn't turn out that way, right? But what did happen was there was a technological innovation, and it was the automobile. But the automobile helped us solve the problem of having 9 feet of manure on all the streets. But it also brought in things like air pollution and things like that. So I think sometimes you have to look at it from that. Next slide, please. So what are unintended consequences as we think about it? So healthcare has had to deal with initiatives that are created for one thing that ultimately change the way our health is and healthcare delivery is in an unintended way. Back up, please. Thank you. And so when we do that, we need to look for the unintended consequences because many times they are created actually not even in healthcare, but from someplace else, and they make a huge difference. For example, the telephone wasn't designed to deliver healthcare, but it's done so for 75 years. So it was designed for communication, but now we do that. Similarly, email wasn't designed to deliver healthcare, but it's been used the same way. We did a study many, many years ago. We're probably the first study looking at electronic mail as a medium for patient-physician communication. And now, everybody with patient portals, things like that, now physicians have to deal with filled mailboxes. But email wasn't created for healthcare. But an unintended consequence then became communication, which now has become slowing up of the ability to provide care. Next slide. So let's think about the EMR. So the EMR was created to actually increase efficiency. So when we think about things, we have to learn how to manage burnout now. There have been plenty of studies now that show that the EMR may increase efficiency, but it actually increases burnout, dealing with all of the things on there. From an education standpoint, we need to teach residents how to manage the EMR. So the EMR wasn't done it, but an unintended consequence of the EMR was that you have to learn how to do other things. And you say, well, but wasn't it there to make things better? It was, but it actually, in some ways, made things worse. Next slide. So here's one that you may know about. For those of you in Canada, it may not be as much, but so in the United States, for a long time, there has been a thing that when you pull up to a red light, you can turn right on red, okay? That was actually created not because of health, but it was created because during the 1970s, there was what was called the Arab oil embargo. And so OPEC created that, and they sort of slowed up the amount of global oil production. So the US had to deal with that. And so what they decided was that sitting at a red light, idling at a red light used too much gas. And so they would actually be better if we could speed up and not do that. So that's why they created right on red. Unfortunately, though, turning right on red has led to an increase in automobile collisions with pedestrians and bike riders. Okay, so some researchers at University of Toronto have actually shown that when you're turning right on red, your attention is looking left. So you're sitting there, you want to turn this way, but you're actually looking this way the whole time. Then people start walking. This is a true story. So I had a research associate And this was in Charleston, South Carolina, and he got hit in exactly that situation. He was going to cross the street and had the right of way. The other person was looking left, turned and hit him. He was put in the hospital, broke his jaw, did some other things like that. So you say, well, but they both could, he had the right of way, but the other person said, well, but it's okay to turn right on red. But this is one of those things where you say, well, what's the unintended consequence of turning right on red? Well, it's hitting people, but it wasn't set up for health. It had nothing to do with health when it was set up. Next slide. So here's one we can think about. When we think of labor-saving devices, we think about like this. We're sitting in front of a computer, okay? And most people do that. Most of the people here are going to do that a lot. But we have labor-saving devices like washing machines, dishwashers, microwave ovens. All these things were created to save labor, to make it easier on people. I mean, I don't think anybody is rushing to want to go to learn and build up their skills to go back to the river and wash clothes on the rocks. But we do have these sort of devices that are coming up all the time. So what we did is we did a study and we said, well, what if you're sedentary? And the reason why we're focusing on sedentary, because that's what, the current, workplace really is. And we were looking at that because people focus quite heavily on BMI and saying that people whose BMI is between 18.5 to 25, those people are healthy. We've done that based on risk. So what we did was we said, let's look at people who are sedentary, who have a healthy BMI. And what we found was that it basically erodes the advantage you have of being at a healthy weight, that your cardiovascular risk on multiple measures and cardiovascular risk in general drives you up, okay? Now, why did that happen? That happened not because of anything nefarious, but because of labor-saving devices. And so you say, well, but that happened and that caused it. Next slide. So this study got a lot of international press. This was actually a cartoon that a Korean media group did for that, and a write-up for that study. Now, I can't read Korean, but I can kind of see the Grim Reaper, coming after somebody sitting at their computer eating a hamburger, or at least a green hamburger. We'll say that. And yeah, I'm assuming if you eat a green hamburger, it's probably even worse. But yeah, so when we look at that, how did that happen? Well, that happened because of an unintended consequence of all these other things. Next slide. Here's one that may strike you as one. You say, well, I'm not sure why you would mention this. Well, medical mission trips are things that students and residents, in fact, they all like to go on medical mission trips to poor countries. It's a good learning experience. It's a bonding experience. You get to go to a sort of an exotic place with substantial needs. A lot of times it's very vulnerable populations. The patients, by the end, are very, very grateful for having people come. And so people spend, the students and residents and faculty, they spend a week and then they leave with a sense of accomplishment and feel like they've made a difference. And they have. Next slide. Unfortunately, there's some unintended consequences to it. And an unintended consequence is that mission trips actually fragment care and undermine the local health system. And so what happens is these folks show up and you say, well, that's, this is really good. But the reality is that it decreases confidence in the local providers. And it fragments care because what happens is the care is not coordinated. And it isn't coordinated with the local provider, but it's not located, it isn't coordinated with the health ministry or the medical school. So a lot of times they're going to places that are organized by churches. And so those may not necessarily be the places of the greatest need, okay? And so This one article I have here was actually written with the dean of the medical school in Port-au-Prince in Haiti. And we had talked a lot about this because it's very difficult for them to sort of coordinate things when people are just sort of willy-nilly dropping in and out in different spots. And so these things also, in terms of understanding what the population needs, typically don't know that much about the population needs. They show up because they're there to have this experience. They focus a lot on infectious disease because it's easy to hand out antibiotics, and usually infectious disease is a common thing. But they really ignore chronic disease because of their short duration of the trip. So they can give a diagnosis, say, oh, I think you've got hypertension, or I think it looks like you may have diabetes. You get 2 weeks worth of medicine, and then these people leave. Well, what we've done is, working with the health ministry in Haiti, is that there is a rise of cardiovascular disease events. Now, let's not talk about what's going on with them right now. I mean, right now is a total disaster. But before the last month, we were able to actually gather some other data. But yeah, so a medical mission trip seems like a good thing. What's not good about going and helping poor people? But the reality is there are unintended consequences on the health system, on the patients, and so on. Next slide. So I want to sort of move over to artificial intelligence. Everybody's talking about this. I mean, you can't. So I'll use a phrase when I was growing up, which I'm sure will not make any sense to most of you. But as they would say, you can't sling a dead cat without hearing somebody talking about how important AI is and what's going to happen. And so you see, plenary speakers, keynote speakers all over the place. AI is great. AI is going to revolutionize everything. AI is our best friend for healthcare. We talk about that. People are very enthusiastic, but I don't think they really look at the implications of AI for medical education. I also don't think they look at the unintended consequences of AI. So a large language model like ChatGPT has essentially upended the general beliefs of what AI can do. A lot of what people were thinking about AI really focused around things like, looking at machine learning and making, some sort of cluster analysis and things like that. Ironically, though, because we're talking about computers, there's been some data that shows that ChatGPT messages in communication with patients is perceived as more empathetic than those written by humans. Now, that's something to consider. Next slide. So what does it do with medical education? Well, there's a lot of fear. There's a lot of very enthusiastic people, oh, AI is going to be our friend. It's not going to do anything. But there's been a significant amount of fear that AI will replace the need for physicians. We know AI can interpret radiographic images and make diagnoses. So with the folks I work with in Haiti, we've tried they've implemented this, and we're still trying to do this for tuberculosis, is that you can take a handheld X-ray machine and have someone who is not a physician, just some sort of trained layperson, have them use a handheld X-ray machine over somebody's chest, and then the AI will decide, well, it can read the image and tell you if they have TB and other things. We also know that AI can make differential diagnoses by just a small amount of information and write the note. So there's a company called Glass Health. That's what they do. That's what they sell, is that it will make the differential diagnosis and it'll write the note for you. We also know that AI can make diagnoses and interpretation pathology. Well, that's a lot of different things there. So how does this relate to medical education? Well, some people have suggested that AI will contribute to the loss of certain skills and roles due to the reliance on AI. So there was an article not too long ago in JAMA where some pathologists said, it was titled, AI's Threat to the Medical Profession. Their contention was that pathologists would rely so much on AI that they would stop learning how to read images, and they would lose their ability to recognize these things. But I think there's another thing that comes up when you start talking about how much are you going to do that? What are you going to do? What is your role? I wrote a thing where I talked about, AI and, how it relates to the Luddites. So for those of you who've heard of the Luddites, most of you probably have not, but those who have, you'll hear people use it as sort of a punchline to people who don't like technology and say, the Luddites were against technology. Oh, you're a Luddite because you don't like to use some sort of new computer program. Well, that's actually not what they were about. What happened was the Luddites were weavers, and the owners of the mills had come up with a new loom. And with that loom, what they could do was you didn't need to go and be an apprentice for many years and go through all that stuff. You could take a much lower skilled person, and with this new technology with the loom, you could have them do that. You could bypass the years of the apprenticeship. So the Luddites were very upset about that because they said, we spent a lot of time in training. We're highly skilled. What you've done is you've taken this new technology and you've redefined our role. And so you've taken us out of being the experts, and anybody can do this. Think about cab drivers in London and how they used to have to take a big test. Well, what do you think happens now when you pick up a phone and you just use GPS? So all of that goes away. And that's what the Luddites, that's why they destroyed the looms. It wasn't so much because they hated the technology. It was that the technology was going to change their role and let somebody who was less skilled put in less time to be able to do their job. Next slide. So what are the unintended consequences of AI for medical education? I think there's a variety of questions to answer. And so this is what I want you to think about. Will what's taught physicians in the corresponding knowledge base be significantly changed and potentially decreased by the emergence of AI? What do we need to teach people for the future? Do we need to teach them how to use, like we do with teaching people how to use an EMR? Or as the pathologists say, hey, we're not gonna be able to read stuff anymore. This is a threat to how we do things. Is it gonna be something where we're gonna have to teach them a different role? Are they gonna have to just focus on algorithm-based diagnoses and wait for the computer to provide the answer? And then you do something different. That's the question. What do you teach them? So when Glass Health basically creates their product is that you just put some information in and then you kind of let the computer do it. So I think that's where we're going to have to think, what is the new role? What are you going to do? What is the computer going to do? I think it's naive when people say, oh, we're going to be exactly the way we are, but this is going to do all this stuff and make my life easier. As I pointed out earlier, there are a lot of labor-saving devices that haven't turned out the way we thought because of unintended consequences. I think we need to also think in a broader thing. Are we doing like the Luddites and we're going to try to survive the medical profession the way it is? Or are we going to have to try to redefine things? So the Luddites said, look, we don't care if you have a new loom and it's so much more efficient. That's actually not very good for us. This is going to actually hurt us because now you have less skilled people can do my job with the help of the technology. Next slide. So one thing that's an unintended consequence that I think probably nobody has really thought about is not, is it going to take people's jobs? Is it going to redefine that? But what does it do in terms of assessment? When we think about assessment, we say, okay, well, how do we know if this student or this trainee learned something? So we got a lot of assessment things. It may be competency-based assessments. It may be other things like that. But one of the things that happens in universities now and in medical schools are open book tests. So an open book test is that I can access this test on a, in a computer, but I have the ability to rely on any resource I can during the time of the test. And so this particular article, which was in Medical Education Online, basically said, hey, what we're going to do is we're going to take like testing. Students love it. They said it's great. You know, I get to do this, you know, and remember, there are many people who talk about it in education, particularly in things that need sort of self-education, lifelong learning, say, well, we don't really need to teach people stuff because the knowledge base changes. They just have to know where to find it. So they do that. So that's really one of the things that's been advocated is that, yeah, let's do an open book. Next slide. And so people have come back and said, hey, let's assess open book examinations in medical education. We need to do that. You say, well, that's great. We know students like it. It's pretty easy to set it up. You don't have to worry about proctoring. You don't have to worry about controlling information. You just give it to them. But AI actually plays a role here. Next slide. So working with Ting Wong, who may actually be on this call, she's a colleague of mine, and she works at the American Board of Family Medicine. We did a study where we looked at whether or not GPT, or ChatGPT, as you're probably familiar with it, how well it can do in terms of taking the family medicine in training exams. That's for the residents. That's to see how well they're doing. And there's a thing that I think there's an unintended consequence and an implication that a lot of people don't think about. Next slide. So what did we find? We found that when we took the 2022 ABFM's in training exam, and we did it with ChatGPT 3.5, then we did it again with the next version up, which is ChatGPT 4, it showed in a 4-month interval that its ability to pass the test went from 56% right to 84% right. That's actually higher than most humans. So what you did was in 4 months, it's now can pass 84%. With a scale score growth from 280 to 690, okay? Now think about that. This can do that. However, what does this mean? Next slide. What it means is that AI can pass the test at rates high or higher than most humans. If we're talking about open book examinations and anything can be accessed, now we have a real question. If open book allows you to use those, then what or who are we actually assessing? What are we assessing? Their ability to use one of these resources? More specifically, what's cheating in this environment? So this came up, this was a direct experience that I had. So I was on a student conduct committee here at University of Florida, and I was brought in because of this exact same thing. There was a test, and so they say, well, we don't want you to use ChatGPT. But the test was open book. And so several people who took this test in this class they said you can use everything but that. And so they came back, and one of the students was charged with cheating. And the instructor said, yeah, well, you can't use that. And the question came up was, I thought you said you could use anything. Well, you can, but just not that. How do you know they use that? I don't. But they did really, really well. Now, again, what are we assessing? Who are we assessing? What's cheating? And that was really where it came down to. It was like, what was considered cheating? So if we say any resource is available, and we have a resource that we know can pass tests, and we know it isn't just for the ones that we looked at, that Ting and I looked at, but we know that it's passed tests in law school, and we know it's passed it in the business schools, and so on. So we know that these things can do that. So what's cheating? How do we do that? How do we regulate that? What are we really looking at? So that's like an unintended consequence of AI. We think AI is going to be our friend. We're going to do all this stuff. But this is something that nobody's really thought about, is what does it mean for how we assess people? Is open book going to go away? Or is that going to be, we're going to have to figure out something different? Next slide. The second thing I want you to think about, besides, you know, seeing things a little bit differently and looking for things like unintended consequences, is I think there's a need for trials in medical education research. I think that we don't do enough of it, and I think it needs to be done. Next slide. So there aren't that many trials as we think of it as a real trial conducted in medical education. You know, a very common design that you'll see over and over is the one group pre-test, post-test design. So very commonly you'd see something like you survey residents before a lecture. So you say, oh, well, I'm going to survey you about your attitudes or knowledge of HIV. We do a rotation, or you do a clerkship, or you just give a, you know, a lecture. And you survey them right after and you say, hey, what do you think now? And a lot of times it's their satisfaction. And typically it's not even an increase in knowledge. It's more like, do you feel more confident? Do you feel better about being able to do this? Well, those are really very weak designs, okay? There's no control group. There's a lot of threats to validity. It has relatively weak outcomes. What Barry Weiss, who used to be the editor of Family Medicine, was called happiness data. You know, we want this stuff to affect health outcomes ultimately when we sort of put this education out. If we can't get to that, we may go a step back and say, well, is it going to change behavior? If we go behind that, we may get down to, did it change their knowledge? Most of these things don't even get to that point. It's, do you feel more comfortable? Did you like it? So it might be, and this is a real one that I came across years ago, was they took medical students, they asked them about doing geriatrics and what they thought of old people. They had them go on this rotation, they came back, and then they came back and they said, what do you think? And amazingly enough, they now said, I think old people are good. Before they said, I don't think old people are that good, but now they think old people are good after this rotation. So I was like, great. But so what? The point is, this is used a lot because it's easy to implement. It's easy to implement because you just sort of roll it out. Give people a survey, have them do it, come back again, do it again, done. These things are also, I think, are pushed by two other, you know, real issues. One is most people who do medical education research don't have a lot of resources at their disposal. So what happens is, you know, people who are doing clinical research or basic science research will go get a big grant and they'll go and do a big study. Most of these folks don't have any money and they don't do that. So they say, well, what is easy for me to do is to collect data on trainees. That's easy to do. So they do that. They're also being pushed to be productive. And so the chairman, the department chairs want them to present at meetings. They want them to get stuff out. So it's pretty easy for people to think up something and do something in 3 months, 2 months, okay? But it's not very good, and it doesn't really move the field forward. What happens is that you'll see these things. I'm going to the Society of Teachers of Family Medicine annual meeting in a month. I've been watching this for many years, is that you will see people give a presentation about their new program, and they haven't even evaluated it. But people will be there going, that's great, this is wonderful, this is just like brilliant. You know, how can we do it? They don't even know if it works. So family medicine really is not very positive about papers with this design. I've been sort of pushing, raising this bar for a long time, because it's one of those things where, are we really building up our knowledge base by filling up journals with papers like this? I don't think we're learning a whole lot and being able to do things. Now, the reason why I also say that is because what happens is that if you adopt some of these programs, you are allocating money and you're allocating workforce to something that you don't even know if it works. Next slide. So another reason why trials are uncommon, besides money and time, is that there is the concern of putting paying customers, that's medical students, into an unproven educational module. So you say, oh, well, I'm going to put you over here. And it's like, oh my gosh, I'm paying, this isn't just something else. I would actually respond to that by saying many of the current educational strategies have little evidence of effectiveness. So there have been, discussions about, does a lecture like this, is this useful, or do we need small group training? Because I used to hear, oh, well, just, a person talking to the audience, that's no good. We want this other. But then when we start comparing, because we don't really do that, a lot of it is, does this feel good? Does this make sense? We also have the idea about educational equivalency. If you give this new thing, is it substandard compared to the old thing? Well, remember, we can always look at that in terms of a trial, and whether it's a superiority trial or whether it's a non-inferiority trial. But remember, many of the current educational strategies have little evidence of effectiveness. Also, I think a lot of people want the shiny new thing. So the shiny new thing is, oh, here's a new way to teach. Here's what we're going to do. Here's this new technology. Everybody wants that. Again, many of the shiny new things have little evidence of effectiveness. So you say, well, we don't want an unproven thing. Oh, but we want the shiny new thing. So also, there are a lot of trouble that can't be done in just a couple of months. It may take a lot longer, a lot more cooperation. Next slide. So there are some alternatives to this design, and I think that they make a lot of sense. You can see some of this. Some of these are much more common in health services research than they are in in educational research. I hit students to think about this all the time, because a lot of times when you want to put something new and shiny into a practice or a clinic, it's very difficult to randomize clinics because they don't want to miss out on the new and shiny. So there are strategies like a delayed entry or a stepped wedge design. So both of those would start with everybody is using the current standard at baseline. Then in the next time frame, we switch some people over. And then another time frame, we switch more people over. So that by the end, everybody has the new and shiny, and everybody had the nothing, had the old and dirty. Okay, so everybody had old and dirty, and everybody has new and shiny. So by the end, that's what we have. But that allows us to treat it like a clustered randomized trial. And that actually, everybody can still win. We see this a lot in, like I said, in some sort of health services sort of implementation, if people do trials. Again, a lot of people who do health services research don't do trials either. What they do is they analyze existing data. Again, that puts us back at the spot of maybe we need some trials. A second way is a quasi-experimental design. This doesn't require randomization. It allows for natural preferences of organizations, but it still gives you a control group. The problem is in finding variables that need to be controlled for, or can you get data on that? So comparing two medical schools may seem easy, but there may be a lot of differences between those schools and the kinds of students that were there and how it's taught. Next slide. So here's a question that I think could benefit from a trial. All right, next slide. So, at least in the United States, we know that medical student class attendance drops off in the second year of medical school. Does that really affect their academic performance on the Step 1 test? Now, the Step 1 test, for those of you who aren't from the United States, the Step 1 test has to be passed for the student to progress into the clinical years. Now, this is an actual question that came to me when I was an associate dean for assessment. They said, hey, we know they are coming. What does this mean? Is this a bad thing? So the question really became, should medical students be forced to go to class, or can they learn just as well with taped lectures and self-study? So when I say taped lecture, it would be like this. So this is going to be taped, and you can do it. That's different than doing an online class. We're not talking about an online course where there's interaction, stuff like that. This is, you don't go to class, you sit at home in your pajamas, You skip class, then you get the taped lecture later. Then you can watch it as many times as you want, kind of like Khan Academy. If you've ever seen Khan Academy, you can go and you can watch those things and you can get all of the PowerPoints and hear what people have to say. You do not get any discussion. There is no discussion. There is no interaction. But you can watch it. If there's a part that you don't understand, you can watch it 50 times. So the question is, does that matter? Well, you could randomize students at one medical school be in either the class attendance group or an online self-study group. You could do that. Another is you could use a quasi-experimental design where school 1 uses class attendance and school 2 uses online self-study. Those are ways to do it. But this is a real question. This is a real question. It's like, does this matter? You know, because if it doesn't matter, then that really affects how we teach people. Again, I can tell you that I can remember when everybody was saying, we don't want basically talking heads just talking to students. It has to be small groups. But I can tell you when I was an associate dean for assessment, student would say, what we want are the taped lectures and self-study, but we only want high yield information within them. Okay? So that becomes a real question. Next slide. So here's another question that I think could benefit from a trial. Next slide. So when Charo first contacted me, she said, well, not first time, when she first contacted me, I was excited about coming to Canada. The next time she contacted me, she said, hey, here's what I said, what do you want me to talk about? And we sort of negotiated. She says, I want you to talk about how we build up the primary care workforce. Okay, that's a good question. How do we do that? We know match rates for family medicine are low. So in the recent match, in the last, I guess, 2 weeks, for U.S. medical school seniors, it was about 9% matched in family medicine. That's pretty low. Also, few, if we're going to talk about primary care in general, few individuals really choose outpatient general internal medicine anymore. Most people who when they count going into internal medicine, they're really talking about people having that as the preliminary part for going into a fellowship like cardiology, or they're going to go be a hospitalist. But when we talk about specialty choice, there have been hundreds of studies that have been conducted on medical student specialty choice. I mean, this isn't new. This has been going on for years and years and years and years on many, many, many different variables. Most of these are cross-sectional, looking for a key variable. But this workforce issue is really important because interest in primary care has dropped so substantially that the Council on Graduate Medical Education has actually dropped their goal of having a certain proportion of U.S. medical student graduates into primary care. It used to be that they said they wanted numbers like 45%, 50% of the workforce was going to be primary care. They don't do that anymore. They say we want a lot. National Academy of Medicine in the last couple of years put out a recent report on primary care, and they actually moved away from a goal of production of primary care physicians to really discussions on primary care providers and teams. Okay, so we talk about the primary care workforce, and we're talking about creating physicians. Now we have some stuff where are people just throwing in the towel? Well, maybe they are, but maybe there's a trial that needs to be done. Next slide. So we know that medical school costs a lot of money, at least in the United States. And we know that it costs a huge amount of money for somebody even from the United States to go to medical school in Canada. We know that's like through the roof. But what we also know is money matters in specialty choice. So a higher salary draws more interest. So Mark Abel has been doing these little studies for years. You can see all the way back to 1989. And basically, he comes up with the same thing that he found in 1989, found in 2008, found in 2016. Future salary tends to drive what you're gonna go into. A lot of that is always justified by saying, I have so much medical school debt that I need to make all this money to be able to pay off this debt. That's the rationale. So we have ways that we can take away the debt, like the National Health Service Corps. But the National Health Service Corps doesn't fall into the model that we have for specialty choice. And the specialty choice model in the United States is that it's an open market and you sort of advertise and make yourself attractive to medical students, and then they choose from there. That it's not really a thing of saying you have to do this, you have to do that. It's really more about, can you be appealing to these folks? Okay. National Health Service Corps doesn't work like that. They basically say, we're going to pay your medical school, but you must enter primary care. You have to do that. So what if students graduate with no debt? Primary care would be more attractive, right? We said that money matters, and people say that they need money to pay off the debt. Well, what if they didn't have any debt? Would it become more attractive? Next slide. So this idea of medical school for free has started popping up. So at the Cleveland Clinic, they actually have a tuition-free medical school. But they're really oriented toward creating physician investigators, okay? So unfortunately, not many people attracted to family medicine really want to spend the last 3 years of medical school just doing research before residency. Now, this isn't like an MD, PhD. This is to get sort of a master's and then keep going. They want to create physician investigators. They also have a pretty small class size of only 32 students a year. So even if everybody went into family medicine and was an investigator, so they're a part-time provider, that's not going to really move the workforce needle very much. So New York University created a program where they're going to be tuition free to everybody. And their first class started in 2019. Now they have more people. They have a class size of 120. So they got a big endowment, and that's what they did. Albert Einstein, in the last 2 months, Albert Einstein College of Medicine received an endowment from a benefactor for $2 billion. That's a lot of money. And they plan to make medical school tuition free as well. All right, so we know that there are ones that are doing it, and they're allowing people to then choose. Not like National Health Service Corps, it's obligation free, but do that. Next slide. So we know that money matters. We know that if that debt is taken away, it should make primary care more attractive, or so people say. So the right question is, does providing medical school tuition free lead to more primary care physicians? So the outcome would be the match rate into family medicine. So when the seniors graduate, what do they go into? So one way would be a quasi-experimental design where school 1 has free tuition and school 2 uses conventional tuition. See what happens. Another is school 1 has one incoming class goes tuition free, and the next class pays conventional tuition. Now, this would be a little stronger because the people who go to the free tuition school like Cleveland Clinic is going to be much different than the people who go to some other schools. But you can have one class go tuition free, next class pays conventional tuition. You can say, well, that's unfair. Well, there's nothing unfair about it. I mean, you could basically just say, this is how much money we have, or we're going to do it like this. You could do that. So by doing that, you could get a better idea as to whether or not people are saying, I want more money to pay debt, or they just say, or it's really, I just want more money. Yes. So next slide, please.
Sorry to interrupt. Just a quick reminder that we only have 9 more minutes.
Well, it's a good thing that I'm on the take-home message slide then, right? So I think the take-home message and conclusion is there are many important questions for medical education research. Some of them may come outside of medicine. I think that I want people to be sensitized to think and see things a little differently. Think of unintended consequences, both in and outside of the medical teaching sphere, because they may make a big difference. And finally, don't shy away from rigorous research designs. They may require some cooperation with other schools and some problem solving, but they can provide the best evidence. Next slide. And there it is, the end. So you wanted me to end? I am ended.
Okay, thank you so much, Professor Mainous. Yes, Raymond, go ahead. We have
Oh, yeah,
15 minutes for questions. Go
yeah, I
ahead.
was just saying, if anybody has any questions or comments, please ask them now. Yes, Dr. Marion Duff.
Hi, Dr. Mainous. Thank you very much for that talk. It was very interesting. So I'm a family physician and I'm the chair of the department here at McGill. I was very interested in your questions about, should medical education be open book? I think absolutely. There are many different models of education, and I went to a medical school where most things were open book, that most of the evaluations were presentation of a clinical problem and you had to solve it, and you could use whatever books or people or resources you needed. So I think that's definitely the way to move in the future, especially as we have all kinds of artificial intelligence and internet resources that you were alluding to that are just available all the time. That being said, I don't think that AI is going to replace physicians. I think it's going to definitely replace parts of what we do, and I think we're going to have to work together with technology, but I think there's an irreplaceable part of medicine that remains in the doctor-patient relationship. So that's just a comment I wanted to make on your talk.
Well, I think it's great. I think I'm not saying it's going to. I'm saying that this is a question that needs to be looked at, because as people talk about it, I don't think you can just say, hey, everything's going to stay exactly the same. Well, the telephone said it's not going to stay exactly the same. EMR says it's not going to stay exactly the same. This says it's not going to stay exactly. There are many, many vendors trying to come up with all kinds of different ways to do it. So I think that you will need to think about what is your role going to be in the future, because it's not going to be the same.
Sarah?
Yes, I have a question. I have very much appreciated your perspective of focusing on the unintended consequences of technology. Many years ago to now, AI, that I'm particularly concerned. You have talked about the impact of AI in medical students assessment and the use of this open book, but I see that also in graduate studies. So the use of these technologies for writing the thesis or writing the assignments of the courses. So the diploma will go to the student, or what is the good percentage of the good way to use these technologies for students to keep learning and ourselves, faculty members, to keep learning, and the rules are not clear, and that the link that you make to the need of a strong evaluative research, program evaluation for quality improvement and evaluative research. And definitely, I think is something that many of us, we are concerned about that, and trying to push the training in sound evaluative research in medical and health professions education. But I would have a question to you. You have talked about the limited resources that we can have in this field of inquiry that it has been existing since 1950s and 1960s. But if you see, for example, the impact factor of the journals in medical education, the highest one is academic medicine, and it doesn't reach 10, when more clinical journals have even thousands of the figure of impact factor. So what we could do in order to have more resources for sound research projects like the ones that you are proposing, because usually the amount of grants for medical education or health professional education is lower than for other disciplines, and we are constrained about that. So we are functioning with small grants most of the time. We are unable, because of not only lack of cognitive resources but material resources, to conduct big trials or very anyways, what we could do. I know that here in Canada it has been a lobbying movement vis-a-vis the Canadian Institutes of Health Research to create an institute in health science education that to my knowledge, so far, it has been not productive at all. So what we could do? Just with these present triggers, that technologies that ChatGPT is imposing at such a high speed that we don't have evidence to know what are the decisions that we should make in that regard.
Yeah, so I think there's, let me answer, you probably had 5 questions there, so I'll try to start with the easiest one first. Why is the impact factor low for medical education journals? Okay, there's really 2 reasons. The first reason is a lot of stuff that gets submitted is weak. So the design is weak and it's hard to, you're not going to see. So remember, with impact factors, other people have to take that data and use it in their next study. And so because those things tend to be relatively localized and so on, a lot of educators aren't scientists in terms of wanting to do their own studies, but it could be useful because they might implement it. So they might read it and implement it, but they're not going to read it and turn it into another thing. So if you look at, and I haven't looked at it lately, but if you look at a thing like, you know, a journal like gastroenterology, most of the people who are going to read that are going to be wanting to do their own studies. So they tend to have a very high impact factor because they're going to take that study and they're going to build it into their study and they're going to cite it. Okay. A lot of people who read medical education say, wow, that's great. Let's do that rather than, well, I'm going to do another study on my own. So I think there's that. The second question is that, again, you tend not to have studies that are going to be really move the field forward. They tend to be very localized things. But what happens when we want to, you know, talk about getting more money into it? Well, I think a lot of that is really going to come from, you know, from doing, asking questions and getting, you're going to have to lobby people who have money to say, we want to do a program, but it's going to be something that we think is going to really make a difference. I think that when you look at a lot of the studies that you will see in these journals, you know, do they justify, you know, $1 million? I mean, probably not. And so I think that if you could get people to think about some of this stuff, I think you could, you know, you might be able to do it. But a lot of it's really going to be lobbying the government or a foundation to say, if we answer this question, this is gonna be different. If you don't do that, then I think they're going to say, okay, well, you know, in other words, there was a guy who used to was one of the first guys who ran the things. It's called HRQ now, Agency for Healthcare Research and Quality, but it was HCPR in the old days. And he basically said, look, there is no race for primary care. There's a race for the cure for cancer. When people come in, you know, that's why cancer and heart disease and diabetes get so much more resources than AHRQ, is because, you know, and there's a primary care section of AHRQ, but that's because they don't have the same lobbying ability to say, if we answer this question, this is going to really make a difference and save a lot of lives.
Okay, yes, I get it, yes.
Sorry, just I see a great point being raised in the chat box. Dr. Wu reflected on Dr. Dove's comment and mentioned that yes, can focus on critical thinking in addition to knowledge. Great thoughts, Marian. Thank you, Dr. Wu.
Yes, because now we are already running out of time. Okay.
Yeah, so we have reached the end of our webinar. Thank you, Dr. Mainous, for joining us today. So please join us next time for our next FMER Advanced Research webinar on April 17th, which will be given by Professor Monica Molinaro from the McGill Institute of Health Science Education, who will be talking about family physicians' moral distress during the COVID-19 pandemic. Thank you, everybody.
All right.
Thank you, Professor Mainous. Thank you very much. And next time that I will invite you, I will try to bring you physically.
Perfect.
To Montreal, okay?
That will make it much more attractive. Yes.
I will try. I will do my best. Thank you so much. And thank you, everybody, for the attendance. And thank you very much. Special thanks to Sima and Raymond. Okay.